speaking on the best practice of venous ulcer in Austria. Professor Creggor.
Yes, let me share my slides. So, thank you very much for the invitation. I brought a case which is not a very common case, and I called it, it's an ulcer case, and was a very challenging ulcer case. That's why I called it Don't Lose Your Nerves, because that was what was happening. What I said to myself all the time, because the patient is getting worse and worse, and the pain was getting more and more, and I kept just keep your nerves, and finally we found a good resolution. So I'd like to present a patient. It was an old patient, 80 years old, and he had a post-traumatic ulcer. That's how he was presented himself to us. And he developed skin changes after an injury he had 6 weeks before. He had a lot of comorbidities. He had a metabolic syndrome. He had diabetic renal insufficiency. He had atrial fibrillation. He had a pacemaker, sleep apnea. So there was a lot of going on in the terms of comorbidities. And he had received several medications when he presented himself. So he had metformin, furosemide, he had statin, and of course, Macromide as well. So that's how he presented himself. So what we can see on this picture is a levator reticularis pattern on both legs, on both lower legs, ulceration with hemorrhagic crusts and also fibrin coats. And also there were some tiny spots of like whitish appearing atrophic areas. And on the other leg, the ulcer situation was a little bit not as dramatic, but still as painful. And he had, in a third ulcer he had on his right foot, fibrin-coated erythemas, very painful. So what are the differential diagnoses for these patients? So first of all, we thought about elevated vasculopathy. We thought about maybe he had some vasculitis going on, like a polyarteritis nodosa. Maybe it was just a leg ulcer due to hypertonia. Maybe it was ulcer ulcus hypertonicum. Maybe it just had peripheral arterial disease. We also thought about calciphylaxis because it was so painful. And of course, we also thought about maybe we thought of a necrosis maybe due to coumarin. And of course, we wanted to rule out that there was some embolization process going on. Maybe it was cholesterol. So what we did a biopsy from the ulcer, and what we can see here is that he had intraluminal. He had a perivascular lymphocyte infiltrate. He had thrombi in the small vessels, as you can see here, and he had erythrocyte extravasations. So bringing it all together, the clinical presentations and the histopathology, we decided for the diagnosis of levator vasculopathy. So of course, this was not the only thing we did. We did a thorough checkup. So he had the C-reactive protein was elevated, as was the erythroid sedimation ESR. ANA and subsets and ANCAs were all negative. As well, the thrombophilia diagnostics were also inconspicuous. The only thing which we found was an elevated homocysteine. And of course, we did some duplex sonography to rule out peripheral arterial disease and couldn't find any relevant pathology concerning this diagnosis. But as it was not very, we couldn't do it to the lower leg. We also did an angiography. We didn't reveal any pathology in the lower leg. And of course, because we all thought about the embolization process going on in the background, maybe had endocarditis, we also did a echocardiography, but there was nothing to be found. What was the therapy? Well, the therapy, first of all, we gave him, we changed the Macromide to enoxaparin. So from the Macromide to a low molecular weight heparin, twice a day in the beginning, then once a day. Then we also, as I will show you later with the photos, the situation didn't get better and it kind of deteriorated. We also started IV immunoglobulins, and he received 9 cycles for 8 months. We also started with pentoxifylline, 300 milligrams twice daily. And because he had hyperhomocystinemia going on in the background, we gave him folic acid and vitamin B. And because of this severe process, we didn't have any infectious parameters, but still he had a lot of pseudomonas in his wounds. We gave him an antibiotics, maybe because we were also kind of desperate because he was not getting better so quickly. And of course, we had appropriate wound therapy with regular mechanical wound cleaning and dressing change once a week. And now this is the follow-up, as you can see. That is the patient in the beginning. And this was like after 2 cycles of immunoglobulins. You see the demarcation of the ulcer. So the area of the ulcer was getting much bigger. And that's when we said to ourselves, don't lose our nerves, don't lose our nerves. The patient was in deep pain, but with the continuation of the treatment, we saw the healing of the ulcers with just conservative therapy, no surgery needed. And after 9 cycles, the patient, the ulcers had totally healed. Let me check 1 moment. So livedoid vasculopathy is like a skin infarction. It's not a very common ulcer problem, but it exists. We have several cases of those. So in general, you have like this livedo-racemosa pattern, which livedo-racemosa is a term that doesn't exist in English, but it's a patchy livedo reticularis pattern. Then you have these white spots of atrophy blanche, and third, but not last, the painful ulceration. Thromboembolic, it's a thromboembolic occlusive disease of the cutaneous vascular plexus. That's why it's like it's not an infarction of the heart, but it's like a skin infarction. And there are several diseases which can be associated with this kind of disease, which can be collagenoses like lupus erythematosus or phospholipid antibody syndrome. It can be coagulation disorders. In our case, it was hyperhomocystinemia, which was associated with. It can be elevated paraproteins. And of course, it can be a chronic venous disease, can be in the background. And the problem with this disease is because it's not as common as a regular venous ulcer. There have been various therapeutic approaches. And the main approach in therapy is to give anticoagulation. There have been now several reports for rivaroxaban, but also still for low molecular weight heparins, which are frequently used. There are cases for pentoxifylline, and there are several cases for immune modulation by EVIC therapy, like we did it in our patient. And it's always important if you have an underlying condition like a collagenoses or like any other vascular disease to correct this disease first. So now I'm at the end of my talk, and I'm happy to receive any questions.
Excellent. That's a fascinating case, and thankfully you got your nerve right until you got the patient off table. So I will open the